Thank you so much for having me. It's really a pleasure today to speak to you about management of metastatic CRPC and really why we need to be treating this disease and why we need to be coming up with additional treatment strategies to help improve survival for patients who have metastatic CRPC. We know metastatic CRPC is a lethal disease, but I think we can do better. So really, what are the goals of treatment when it comes to metastatic CRPC? And are our treatments actually achieving these goals? The two goals of treatments, I would say, are one, improve quality of life for patients, ensuring that they have sustained good quality of life as their cancer progresses. And two, improve overall survival. We need to make sure that our therapies actually are making people live longer, as opposed to making fluctuations in PSA or fluctuations in imaging findings. Are our therapies actually making people live longer? The treatment landscape for advanced prostate cancer has really been evolving over the last several decades. The majority of patients present with localized disease, but we know that a subset of those patients ends up recurring. And there are a fraction of patients who actually present with de novo metastatic prostate cancer right from the floodgates. And so the treatments have really been changing, and treatments are moving in earlier into the treatment landscape with introduction of AR targeting agents for metastatic hormone sensitive disease, treating non-metastatic CRPC with AR blockers like apalutamide, enzalutamide, and darolutamide. And really, I think we're making people live longer, I think, with the introduction of these agents into the clinic. So here is that list again. This is all of the FDA approved agents in metastatic CRPC. And really this list launches with docetaxel in 2004 that was approved because of improvements in overall survival. And we see a series of drugs enter into the treatment landscape, including chemotherapy agents, AR pathway targeting agents, such as abiraterone, a CYP17 inhibitor, enzalutamide, an AR blocker. We see radium-223, a liquid radiopharmaceutical, pembrolizumab for the pan indication of both mismatch repair or MSI high tumors, and olaparib and rucaparib for patients that have homologous recombination repair gene alterations. So here is that list. And as we're thinking about one of our first goals for metastatic CRPC, the question of, are we actually making people live longer? And when we look at all of the FDA approved agents, they are nearly all improving overall survival compared to the control arm in the context of these studies. The only two agents on this list that have not demonstrated to improve overall survival include pembrolizumab, as this indication was granted for the tumor agnostic histology of patients that have mismatch repair. And we know that 1% to 2% of patients who have prostate cancer fall into that category. Rucaparib was approved based on the phase 2 data from Triton-2, and there is currently a large phase 3 confirmatory study that is ongoing to help validate the results of the phase 2. So nearly every drug on the list that is used to treat metastatic CRPC has demonstrated improvements in overall survival. Now, I know we're not really supposed to do this, but I'm going to do it anyway, as we think about where we've come in the field with the improvement of overall survival with all of these new drugs entering into the clinic. So if we look at the overall survival from the TAC trial of docetaxel, the overall survival from the time patients entered into the study was 18.9 months for patients that were on the treatment arm. If we go to 2011, with the introduction of abiraterone in the post-chemotherapy setting, now keeping in mind, we're now moving abiraterone way early on into patients who have hormone-sensitive disease, but as a point of context to show that we actually are improving OS, patients were mandated to have received prior docetaxel from the Cougar 301 trial. And if we look at the overall survival following docetaxel, the overall survival of patients that were on Cougar 301 is 15.8 months. And we sum that to the 18.9 months, we're at 34.7 months. And now if we go to 2019, we've got docetaxel, we've got abiraterone. The cabazitaxel trial mandated that patients had received prior docetaxel and also prior abiraterone. And we sum that in here, the 13.6 month OS benefit from cabazitaxel in this concept, we're up to 53.6 months. Now, granted, likely one of these agents was potentially could have been given in the metastatic hormone sensitive setting, but unlikely that both of these agents were given in that context. So I do think we are in fact making patients live longer with the introduction of these drugs into the clinic. So the second goal of therapy is to actually improve quality of life, improve cancer-associated pain, improve urinary symptoms, specifically related to local disease, especially for patients that have an intact primary, decrease symptomatic skeletal events, and mitigate treatment-associated side effects. So again, taking that same list of all of the FDA-approved agents that we use to treat metastatic CRPC, and nearly all of the agents that have been tested have reported out on quality of life and have demonstrated improvement of quality of life compared to the control arm. Now, I know quality of life is very difficult to assess. The instruments are not standardized, across all of our studies, but the data that is out there thus far is that actually treating patients with advanced disease does improve their quality of life compared to just letting the disease go untreated. And so again, nearly all life-prolonging therapies, with the exception of CRPC, which is done by definition in an asymptomatic patient population, have demonstrated improvements in patient-reported quality of life. So as we think about in clinical practice, this disease is grossly undertreated. The majority of patients never see second line, never see third line, fourth line, or certainly not fifth line therapy. And so I think we can do better with regards to actually appropriately treating this disease in the community. And just a word about cost effectiveness. I think this always comes up about, well, what is the value of any given therapy? Are we actually implementing new interventions that are more costly and more effective when we think about the downsides and risks and side effects and cost of any given therapy? I will say that I think there's limited unbiased studies that investigate cost effectiveness into the context of metastatic CRPC. There's inconsistent methodologies. There's ambiguity in assessing improvements or decrements of health. And the results are difficult to interpret, especially when we're looking at measuring multiple measures. And hopefully in the future, I think we can shift the paradigm from a one-size-fits-all model to actually a more precision-based medicine model to help maximize efficacy and minimize toxicity, in the context of the therapies that we administer in the clinic. And I think we are moving towards that. We are moving towards these biomarker-based strategies with, the approval of pembrolizumab, with the approval of PARP inhibitors, and hopefully down the line, there'll be additional drugs that'll enter into the clinic that are biomarker-based. The landscape of alterations in prostate cancer is certainly being defined. We see alterations in the WNT pathway, the PIK3 CA pathway, the AR pathway, and various other pathways. Additionally, there's a long tail of alterations that are present in patients who have advanced prostate cancer. And while each of these alterations is low in number, when we sum up all of these rare alterations, they almost account for 30% of all advanced prostate cancer. So I think we need to figure out how to do a better job of precisely targeting this disease. And I will kind of put this teaser up here of a phase 2 umbrella study that is currently in development through the Alliance with myself, Dr. Beltran, Misha Beltran at the Dana-Farber, Glenn Heller at MSKCC, Michael Morris, and Chuck Ryan. So this trial is currently in development where we're looking at actually utilizing a biomarker-based strategy that uses both DNA and RNA to help with treatment allocation, really to help maximize efficacy of any drug or drug combination. So should we treat metastatic CRPC? Yes, we know that treatments improve overall survival. They improve quality of life. There are novel therapeutics and treatment paradigms that are actively being investigated with the goal of maximizing efficacy and limiting toxicity. Thank you so much for your time.
David asked me to do the con for the treatment of metastatic CRPC. Full disclosure, I'm a medical oncologist. My life's work is to treat advanced prostate cancer. And he wants me to tell you that my life's work is crap, okay? So I'll go ahead and do this. I'm gonna try not to cry. So here we go. All right, are we overtreating mCRPC? All right, so the question is, should patients with advanced prostate cancer get maximal systemic therapy? The pro would be survival if you value that kind of thing. quality of life, if you think that matters. The con potentially is quality of life. Certainly there's toxicity. Certainly there's financial toxicity. We won't overlook that. Certainly we have to talk about patient-centric treatment strategies. All right, so, we've seen this slide before. This is an extremely important concept. Dr. Shore published in Advances in Therapy. And what this is showing is through 5 lines of therapy, okay, a couple of things. Number one, how many patients are actually getting treatment, right? And so one take home here is it falls off very quickly. I mean, first line therapy, yes, most people get it. And then what do they get? Well, largely they're getting hormonal agents. By the time you get to second line therapy, you've lost almost half the patients, right? By the time you get to fourth line therapy, I mean, you're talking about 15, 20% of the patients getting treated. So there is a rapid drop off, and this reflects a number of things. This reflects patients passing away. As much as Dr. McKay showed, you might get through 3 lines of therapy, that's the goal, but in reality, most patients don't get past the second line. It does reflect the accumulation of toxicities. Perhaps one could interpret this to say that there's gross undertreatment. Maybe, maybe not. That's a debatable point. It does reflect the fact that real-world patients are different from trial patients. They are less tolerant of toxicity. They're older. They're more frail, right? And then, there's a question of, are the clinicians in community practice different from those in academic practice, right? What is their focus? Do they have a different value set in terms of, individual benefit, societal benefit, et cetera? So in 2021, I mean, what's the status? Let's assume that most patients are getting ADT monotherapy in the first-line setting, since, in fact, that's true. Most patients are just getting ADT monotherapy, despite the data. And if you think about a typical progression, you might say in second line, you'll go on a next-generation androgen receptor pathway inhibitor, AbbVie or Enza. Maybe you slip CYP in there somewhere. Let's call that half a line of therapy. Then, perhaps the patient goes on the other oral agent or docetaxel. After that, they go on dosi. And after that, do you slip radium in here somewhere? Is there a PARP inhibitor for select studies? But that's it. With that, we've talked about every available drug, right? So there's not actually that much in our armamentarium. And I'm not sure, how much patients are being kind of taught or guided through this thought process of, how much is actually available. This is the difficult part. What happens when we're at 5th line, in the clinic for those of us who treat advanced prostate cancer? So, the points here is after second line, for almost all patients, all that's left is chemo, right? There's not anything else. All options beyond third line are going to be myelosuppressive. All the toxicities that go with that. And remember, the real-world population is older, more frail than the clinical trial population. These patients had radiation to their pelvis, perhaps, so their marrow reserve can be quite poor. And then the combination of patients that drop out and the cumulative toxicity mean that very few patients are going to see more than 4 lines of therapy. Now, you might, and Dr. McKay did some of this, as we talk about survival by line of therapy, in the first line now we have finally a trial that shows 5 years of overall survival in a high-risk patient population. That's incredibly encouraging despite all the problems with that study design. In the second line, we talk about something a bit less than 3 years. In the third line, we're talking about 15 months. Third, fourth line, now we're talking about a year. This is very important when we're talking to our patients. I'm not sure this always gets framed appropriately. Once you get beyond second line therapy, the expectations is patients are down to their last year. And I think they need to understand that as we're trying to discuss what are their treatment options and what should we do. We really don't have any good trials saying that you're going to get more than a year, year and a half survival beyond second line therapy. Then there's the fact that data changes, right? So, we always talk about levels of evidence. We always talk about applying, data to the appropriate patient population. But, the reality is that in the clinic every day, less than half of the patients I treat actually get treatment for which they would have qualified for the clinical trial. Everything is an extrapolation, right? Almost every patient, if I'm being very strict about applying clinical trial data, almost everybody I treat is being treated differently than the clinical trial. So all the data then is an approximation for them. The TROPIC study, for example, represents a population which no longer exists. Nobody goes from ADT to DOSI to CABASI because ABI and ENZA and all the other androgen pathway inhibitors didn't exist at the time of the TROPIC study. The CARD study that we cite so much as saying cabazitaxel is better than an androgen receptor pathway inhibitor, I mean, this study was designed to be absolutely optimal for cabazitaxel, right? And it really represents a subset of our patient population. It's not that the results are invalid. It's not that the results don't represent a true outcome for the patients that were tested, but they definitely put their thumb heavily on the scale to make sure that the study would be positive. The results, I think, are true, but you have to think about the generalizability to all the rest of the patients. And then the VISION study, an important study. Hopefully we're going to see some FDA commentary on this in the very near future. But we do have to recognize that the patient population tested here were extremely fit, extremely mobile. Again, once you start talking about third, fourth line therapy, right, 80% of the patients have already passed away or are no longer trial eligible, right? So this is really an extremely small subset of all of our patients, despite all the excitement that comes from these studies. And then, we always make the point, look, individual patients are not like trial patients. We don't have to dogmatically apply all of the results to every patient. So this is a real patient that I see in clinic, a 73-year-old man. He has Parkinson's disease, initially treated in 2015 with a radical prostatectomy, but unfortunately, post-op, he had a detectable PSA, so of course an ominous finding, we all know this. PSA started rising very quickly, and in fact, we biopsied, actually, one of my colleagues biopsied and found metastatic prostate cancer in a regional lymph node. So he undergoes salvage lymphadenectomy, begins adjuvant bicalutamide, and gets only a very brief benefit before the PSA starts going up again, and now he has bone metastases. So, this patient in just over a year went from localized disease to now metastatic disease, and I think we all know that this is ominous, and any of the data in 2016 would say that the expected survival is perhaps, 3 years. The patient then develops pulmonary metastases and now visceral disease, right? So the story is getting worse, but he has advanced Parkinson's. And with Parkinson's patients, this is not a rare scenario in clinic. Obviously, Parkinson's is the disease of aging. I have many patients actually with this combination. And a very common conversation for us is, we're not going to treat you for the prostate cancer with ADT. If I take away 30% of the strength, the muscle mass of a man with Parkinson's, his risk of fall goes up, the morbidity goes up incredibly, his quality of life goes down very quickly and very significantly. So we have these conversations that we're not going to treat, rather we're going to follow symptomatically. We're going to try to hold off on treatment as long as we possibly can, because the goal of everything we do is maximum quality life. And so this patient followed serially by choline PET CTs, because we have that at my institution. And you can see this consistent progression off therapy, but this is 4 years, right? By data, he should have been dead from his prostate cancer by now. But patients, aren't data. Each patient is different. You can individualize your treatment approach. And past behavior is the best predictor of future behavior, right? So we have a little bit of room to watch a patient and let the disease declare itself biologically, and that's what we did here. So in fact, he did very well until just this year, when we finally said there's enough disease now, the burden is significant enough, we think that the process is accelerating, so we're doing intermittent ADT, right? We're just going to try to keep the disease in the background and keep him going as long as possible. So he's been alive for 5 years with a total of 2 years of bicalutamide, 3 months of ADT. This is not guideline consistent therapy at all, right? So I think physicians actually really know who's going to do well and who isn't. And when we're wrong, we actually find out very quickly, right? We have a little bit of room to maneuver and let the disease declare itself. So we have to keep in mind always that patient selection will impact trial results and then the applicability of results to our individual patients. And we really should individualize our treatment decisions to optimize outcomes. And then financial toxicity, not to be overlooked. but financial toxicity is significant, and patients are reporting that this significantly impacts their quality of life and their mental health, and of course their family as well. And there is, of course, a socioeconomic component to thinking about financial toxicity. Keep in mind, treatment in these settings is chronic and it can extend for years. So in conclusion, just because we can doesn't mean we should. Trials testing beyond third-line therapy do not reflect real-world patients, and toxicity will always be worse and outcomes poorer in real-world patients. This is a dogmatic truth in all of our trials. Financial burden is significant and can't be overlooked, so experienced clinicians should exercise prudent judgment in deciding whether or not to treat patients with advanced cancer.